Good afternoon and welcome everyone to the Health and Adult Social Care Scrutiny panel today, and it's Thursday 8th of July. This meeting it's a virtual meeting and it is being webcast live. Can I ask members of the panel to raise their hand function when they wish to speak? Can I ask, I'm going to introduce myself first, and can I ask members of the panel to introduce themselves? I'm Councillor Habib Anzaman and I'm the chair of the panel. Leslie? I can't hear you, Leslie.
Sorry, I'm Councillor Leslie Warner, representing Colne Valley, and I'm also a director of the Hospital Trust.
Vivian?
Councillor Vivian Lees Hamilton, panel member and representative for Murfield Ward. Thank you.
Bill?
Yes, Councillor Bill Armour, representative Kirkburton Ward and a panel member.
Fazila?
Councillor Fazila Lunat, panel member and a councillor for Batley West. Batley East.
Batley East. David Rigby, co-optee.
Yeah, it's Dave Rigby and I'm a co-optee.
Okay. And we have apologies from anyone, Richard?
I haven't received any formal apologies, but at the moment Councillor Butt is not attending, so it looks as if Councillor Butt will have sent his apologies.
Okay. And Lynn?
Do
Richard,
apologise. Yes, do apologise. Lynn Keedy, co-optee, has given her formal apologies for this meeting.
Okay, thank you. Okay. Can we move on to item 1, which is minutes of the previous meeting? Are they a true record? Would anyone like to move them?
Happy to move them and approve.
Yeah.
Thank you. Item 2. There's some background noise that I can hear. Okay, item 2. Any board members who wish to declare any pecuniary interests? Either declare now or you please fill in the form that's within your packs and return those to the appropriate officer. Item 3, admissions of the public. We have no admissions at this meeting today. Item 4, deputations and petitions. Again, we have no petitions and deputations at this meeting today. Item 5, public question time. We have no questions at this meeting. Item 6, we have Yorkshire Ambulance Service, who will be giving us an update on their service. So if I could invite John McSorley, the Head of Operations for the West Yorkshire Division, and Andy Simpson to give us an update, please.
Afternoon all, I'm John McSorley, Head of Operations, and my colleague Andrew Simpson, Deputy Head of Operations. He'll lead on the presentations and we'll answer any questions that the committee has. Thank you.
Good afternoon all. I sent through the presentation quite a while ago now, so I've just spent a bit of time going through it, and just so that I can update you on any sort of key points. I'll be talking through the presentation from slide 9, which starts presentation, funnily enough. All the information prior to that is just for your information, for anybody that's not fully familiar with how the ambulance service operates. But I'm happy to take questions now or as the presentation goes on, or at the end, as you see fit. But feel free to try and make this an open discussion rather than just me talking. So the key points of scrutiny that I was asked to report on was how the service has coped and adapted to the current pandemic challenges, and also there was an issue around ambulance performance, which I was asked to report on, especially progress from last year. So So service challenges and COVID-19, that's the slide we're on now. I think it's fair to say both myself and John have been in the ambulance service now for over 30 years, and I'm sure you've heard this said many times before in many forums, but this year has been completely unprecedented in terms of the challenges that we've faced across the ambulance service. And when I talk about the ambulance service, I'm talking about NHS 111, I'm talking about the patient transport service, and I'm talking about the 999 service, because obviously we look after all those free services and they are inextricably linked in terms of our dependency on each other. Also, those challenges have been cross-boundary across all health boundaries as well, when it's working with acute trusts, when working with urgent care providers and primary care and all the other key stakeholders within the service. Those challenges have been paramount, and it's been a real steep learning curve on how to adapt, how to learn, and to put actions in place to make sure that we maintain a service to the most in clinical need within our area of responsibility. So I've split the challenges into 3 key areas. I've put it around workforce and staff welfare. I've put it around how we've managed the differences in demand and the high demand, and I've talked about specifically about the infection prevention and control around the health and safety of our crews. So from a workforce and staff welfare point of view, the key sort of challenges for us, and are probably still in place now, have been around the high staff absence. So normally around this time of year, we plan for around 3 to 4% absence. At the moment, we are operating in the region of 10% absence. So 10% of our workforce is missing, either through isolation, being symptomatic, or through very efficient track and trace systems. Obviously, we are adhering to those track and trace adamantly from a point of view of the patients that we serve are clinically vulnerable. So it's essential that our staff are safe in order to treat patients safely. But that has had a big impact on us. During the peak of the pandemic, we were in excess of 20% of our staff absent, and I know that is pretty similar to other health agencies across that we have worked with when we've benchmarked those standards with them. So we've had to think of innovative ways to try and manage around that. So what with the staff that were clinically vulnerable, we've looked at their skill set, we've looked at additional roles that they could fulfill and support operational demand. Some of those staff, for example, were moved off frontline duties, but were put into still patient-facing, but using clinical triage tools, working from home or in our emergency operations centre, so that the risk was reduced, but they still were able to serve the patients and be operationally effective. We looked at the lower acuity support for 999 services, and we looked at ways of how we could increase that. If we increase the low acuity, that then releases those resources to manage the high acuity. So we looked at our CFR colleagues, highly trained individuals, usually from clinical backgrounds. Some of those were furloughed, so we looked at supplying additional training and paying those individuals. They supported our PTS service, and our PTS service supported the A&E service. So it was a sort of a step-up approach in order to ensure that resources were focused on the front line. We developed ways of home working. I think we all agree that Microsoft Teams now has become a part of what we do. So we've embraced that. We tried to make the emergency operations centres to make those virtual, so that rather than staff travelling 20 miles up a motorway to work in an EOC, they could simply log on when we were in peak demand and support the service that way. So we've invested heavily in IT systems and training in order to do that. We've looked at a lot of our support functions. We stood those down. So the support functions such as our clinical governance forums and things like that, where we've got a lot of clinicians working on policies and procedures. A lot of those were suspended, and those clinicians were moved to the front line in senior roles, mainly working in the emergency operations centre, supporting clinical decision making, supporting triage to make sure that the most clinically in need got the services they needed. I'll move on to the next slide if I may, which is about managing demand. So the demand for an ambulance service, and I'm not just Yorkshire Ambulance Service, but any service nationally, generally follows a pretty predictable pattern. We can forecast that relatively easily, and usually we can forecast that by hour, usually plus or minus a couple of % accuracy. So obviously our normal pattern of demand changes on a 24-hour period, hour by hour, and it also changes seasonally. We're much busier in winter than we would be in summer, for example. And like I say, that's predictable. We can map that. It's fair to say that the last year bucked the trend, and also that is continuing into this year. We're not seeing that typical pattern that our rosters are matched to. So that is causing us all sorts of issues. To try and manage that demand, as you're aware, NHS 11 became the gateway for COVID and the pandemic. That led to an absolutely incredible amount of demand placed upon them. They responded to that by putting additional resources on, and that protected in some ways the health service and the ambulance service, because it became a gateway. It signposted patients to appropriate services rather than just dispatching ambulances and flooding the acute trusts. Increased clinical capacity from the senior clinicians I talked about. They supported those call takers in order to make those decisions. And also we embraced the video assisted culture. Quite normal for us, but I think the population as a whole has become used to video conferencing. Who hasn't had a family Zoom quiz in the last 12 months? So I think it's become the norm to use this type of technology. Where it isn't the norm is where you've got a health problem to actually sit and discuss with the clinician. But we've embraced that technology, and so have our patients. And I've provided some figures there that during the peak we did over 600 video consultations. And there's a question there from Councillor Lunat.
Hi, Andrew. So just a question in regards to your managing demands. In terms of how staff is dealing with the transfer times when they're giving the patients handover and doing handovers at the hospitals, how has managing demand worked with patient transfer times, kind of thing? And are you still struggling in terms of doing the transfer?
The handover times were a major problem for us because of the high demand going into the acute trusts, with the added complexity of having a green and a red entrance into the ambulance trusts, because obviously COVID patients had to be kept separate from the non-COVID patients. So as the pandemic increased, the red doors and the red capacity had to be increased, but then as the peak subsided, it had to go the other way. So we were in a constantly evolving picture. The acute trust managed fantastically. Again, we put new ways of working where we did pre-alerts. So we had additional triage nurses at the front door to direct us, but inevitably it did lead to delays. But it led to delays for patients that were less clinically vulnerable. The most clinically vulnerable patients, there were no delays for those. Although, if you look at our handover times, they were excessive. But those patients, if I dare say it, were able to wait. The ones that couldn't wait were taken. There was always capacity within the A&E department to go straight in. But to answer your question, it did have a big impact on us. I think the other impact on us was the wrap-up time. So when the crew came out to them coming clear, obviously we had to follow some really intensive infection prevention control measures of cleaning the ambulance. So we'd expect an ambulance to turn around within 15 minutes. I think we were doing that in 30-40 minutes because the ambulance had to be cleaned. We stopped very quickly. We stopped the crews doing that, and we put in cleaning teams. We got private providers through cleaning agencies. So literally, as it was a little bit like a Formula One pit stop, but not quite as fast. But literally, as the crew came in, took the patient into the apartment, there was a team of cleaners straight into the back of the ambulance, wiped all down the surfaces, restocked the vehicle for them. So when the crew came out, they was able then to respond to another emergency. And we've kept that model going at certain key hospitals right up until now. But at that point in the pandemic, it was at every hospital. Councillor Warner.
Thank you.
Thank you. Yeah, this is. I've got some questions on behalf of Linkedium. One of them, she says, referring to the slide you've just said. She says, "Are there any recontact rate figures available appertaining to the highlighted new ways of working? And what are the related lessons that have been learned? Is there, if there is evidence of a predominance of successful outcomes, is it the intention to continue to maintain this blended response approach going forward?"
We do monitor recontact rates, especially within EOC and 111. Whether we do that for 999 calls, I'm not too sure, but I can certainly ask that question. In terms of learning the lessons, the key lessons for us around the clinical triage. So I've mentioned here around the hear and treat. I think that's always been a big agenda for us, you know, in Yorkshire Ambulance Service. To invest in putting clinicians within the clinical hub, within the emergency operations centre. So as the emergency calls come in, they're triaged. Categories 1 is the highest, down to 4. Any patients that would fall into a 4 or 5 category, there's a potential there for them to for a clinician to ring them back and actually discuss their condition and decide on a most appropriate pathway, as opposed to dispatching an ambulance. I think pre-pandemic we were around 7-8% at best. I think the best in the country was around 10%, so we aspired to that. I think the additional training, the lessons learned, the additional resources we've put into that, we're in excess of 10% most days, and yesterday we were at 12%. So it's examples like that, it's the lessons like that in managers' demand that we've been able to take on board. I know one of the other major lessons that we learned was when we had an outbreak within our emergency operations centre. So we lost a lot of call takers in one go. What we were able to do is virtually manage the calls, have the calls managed by other ambulance services. So again, there was no delays for the patient, even though when that patient rang 999 who lived in Batley, the actual emergency call was probably taken by somebody up in North East Ambulance Service or North West Ambulance Service. The emergency call is transferred virtually to our CAD and dispatched as normal. So it's those sort of lessons and technology that we've taken from this pandemic, which have been really useful and will serve as well in terms of business continuity going forward.
Councillor Bilama, do you want to ask your question?
Yes, thank you. A couple really. First one is to do with response times. I appreciate what you've said about the effects of COVID, but the area I represent is part of the HD8 postcode area, and we do have, or perceive problems anyway, with response times being a little bit overlong. I've no doubt.
Sorry, Councillor Armour, we've lost you.
Can you hear me now?
Yes.
Right. Let's talk about the HD8 area and response times, and not necessarily COVID related. And I appreciate what you said about the effects of COVID, but the general perception is that we're having increased response times, partly because, as I understand it, policy is not to maintain ambulances locally, but to have them out on the road on air. And the problem with that is it creates a bit of a donut effect, because as the day progresses, as the shift progresses, ambulances tend to be drawn towards hospitals where they're dropping off. And that leaves a donut around, for example, Honley in the HD8 area, which would have served it, but doesn't now, because your Honley ambulance crews may be at Barnsley Hospital, maybe at Wakefield, maybe at Huddersfield, Halifax. So we seem to get what is perceived as an inferior service, and I am worried about the apparent longer response times.
Yeah, if I can just answer a couple of those points. Certainly, there's no policy. I mean, if I take a comparable service, the fire service, the fire service have 10% efficiency. So, in other words, time on task 10%, 90% they're sat waiting for an emergency call. If I can compare, just to use that for the context, the ambulance service runs at 95% capacity. So there is no policy about keeping crews out. The only thing that keeps crews out is the demand that's coming in through those telephone lines. So at the moment, our crews, our systems are running so hot, there is no downtime for the crews. The crews literally come onto the station, pick up their vehicle, and there's call stacking, and they go straight out. They come back in for a meal break. They have the half-hour meal break. There's call stacking. They go straight back out. So to answer your question, there's no policy about keeping crews out. The demand keeps the crews out. That's the ambulance service. If you watch, it's been well publicised on BBC One programmes. There's some real life fly on the wall documentaries, and a lot of those have been designed to try and educate the public as to how the decisions that are made within that AOC around dispatching ambulances, because it is a big decision to dispatch an ambulance. So yeah, I take your point around the HD8, HD9. All since the pandemic, certainly the lockdown measures that were put in, and I'll refer this in the next slide if I may. If you just if you go on to the next probably slide.
Andrew, just before you move on to that, just as a follow-up on Councillor Bilama's question, for WF13, that is one of the highest category 1 calls that you've had. That you've had 514 calls on that, compared to HD7, where you've had 154 calls.
Yeah.
Are you able to tell us what the patterns of these call outs are, in terms of how serious and what are they related to, just so that we get an understanding of why there seems to be a much higher call out in the WF13 area?
If I may, if you can just allow me to continue with presentation as I've put it down, because I've got some specific slides around performance, and then I'll try and pick up those points. But by all means, just remind me if I do it. But I'll try and pick those points up so that it remains logical, if you see what I mean, because I may answer some of the questions anyway. So just to quickly, the infection prevention control slide, I've talked about making the ambulance stations COVID secure. That's across all public buildings. I've talked about making sure the health and safety of our crews is paramount. We were able to procure gold standard PPE in terms of the hoods. I've got a picture there for you. Look very dramatic, but fantastic in terms of crew protection. And it gives staff a lot of assurance and a lot of confidence in managing COVID positive patients, especially when doing procedures that were extremely infectious, that were aerosol generating procedures. And I've talked about the cleaning teams. So ambulance response standards, I've talked about the 4 categories. When our calls come in, they're categorised into four categories. So category 1 should be a 7-minute response on average. Category 2, 18 minutes. These 3 and 4, but those are locally negotiated. But just to say, a lot of those calls can be managed by low acuity crews and can be managed via our clinicians in EOC, which I've already spoke about. Next slide is around the previous year comparison. So despite the challenges, looking at category 1 and category 2, there was minimal changes in terms of the response times. I think they increased category 1 25 seconds and 43 seconds respectively. and 3 seconds and 53 seconds for category 2. That was largely in main to some of the impacts delivered via lockdown. Councillor Warner.
I know you've given us this probably in another meeting, but it would be helpful if you could remind us what the different categories stand for.
Yes, if you were, I'll give you a quick rundown of those. So, yeah, as I said, a lot of that was mainly down to the national lockdown. If you go to the next slide, or sorry, not the next slide, the next one after, because that's just giving you a breakdown of what I've included in terms of postcode areas. And I've given you a category 1 response times. Now I've done that in the form of a heat map for you. So our category 1 are the most seriously ill patients, just to answer your question. So the type of patients I would expect to see in this category are cardiac arrest, choking, severe hemorrhage. Those are the type of patients we would see that. This is our smallest category in terms of demand. So we would see about 10% of our overall call volume being in Cat 1. So these patients are seriously ill, but also they're the most resource intensive, because although it's one emergency call, we may send multiple resources to these patients because they need specialist clinical skills, excuse me. For example, we may send a critical care paramedic either via the heart team or via Yorkshire Air Ambulance. We would send an ambulance initially as initial response, but we may send a rapid response vehicle as well, or multiple resources to manage that scene, because that patient needs that level of nursing. If you look at those category 1 response times, very small amount. So if you look at, you mentioned WF13, which is the highest demand area, there's a range of 1 to 2 calls per day on average. So as you can see, very small volumes. And when you go out to HD7, HD8, they're smaller, because obviously it's a more rural part of the patch in comparison to that WF13, which is sort of Dewsbury, Wakefield areas. Category 2, you can see here quite clearly our changes in demand between summer and winter. Obviously, the busier we get, the higher demand and the slower the response times, because our crew efficiency reduces. So as you can see, through the winter months, you get a longer response by the red heat maps, and in summer we're getting a slower response. You can quite clearly see there as well. We went into lockdown sort of March, April, May, June, and then we come out of lockdown in August. You can see the massive step change that we saw in August as national lockdown measures were reduced, as we suddenly became much busier. So category 2 patients, still clinically vulnerable, make up 60% of our demand. So in those type of categories, we've got chest pains, difficulty breathing, asthmas, we've got road traffic accidents, house fires, those type of incidents. So as you can see, still very clinically vulnerable patients. Response time for those patients would be 18 minutes on average. Again, if you look at our busiest area, WF13, if we looked at that from a postcode point of view, we range between 6 to 10 calls between summer and winter per day on average. So just to pick up some of the point, I've answered your question around what type of patients fall into those category 1, category 2, Councillor Warner. Yeah, Councillor Armour, just to pick up some of the points you talked about, you can see there the demand around HD7, HD8. The demand in all areas is high, and what you tend to get at, what you tend to, there's some elements of truth for what you said, because those demanding high areas, it tends to suck resource from your outlying areas. So what we try and do is put standby points in those areas. So when there's capacity allows, we can move resources out. But when we're running at 95% capacity, our opportunity to do that is reduced. So the demand is inextricably linked from that point of view. What we've tried to do from a demand point of view is to ensure that recruitment is on track. So our recruitment does wax and wane, as you would expect, but we are reaching full establishment via the end of August. We've got a new cohort of student paramedics that are due to qualify. They will come out and join us all throughout the summer. So that they will bring us to full establishment. That brings its challenges in terms of having new clinicians with us. So we've got a very intensive mentorship and preceptorship in order to support them, as well as the senior clinicians we've got in EOC to allow them to support their clinical decisions. But yeah, we try to make sure that we have no vacancies and we're over establishing wherever possible. We have increased our overtime budgets. That is as limited impact because obviously staff are tired. They've had 12 months of this, so it's limited. So we're looking at ways of supporting them through additional welfare, making sure there's food, drinks available at key times, so to keep them going, an army marches on its stomach sort of philosophy. We've got a very good demand management plan, which escalates to make sure that the key patients are protected, so that the delays are felt at the low acuity side rather than the high acuity patients. Increasing triage within EOC to make sure that those calls are managed effectively. We're sending quite a lot of public education messages out and key communications to manage the public expectations, telling them the health services are under pressure. I think the public are getting that because that's been, right down from government briefings, right down to local level, those messages have been heard. We are looking at PTS to support A&E colleagues, and we're also looking at private providers such as St John's Ambulance, procuring some services from them to support us with low acuity patients, which then allows us to manage the high acuity stuff. So that's the sort of areas we're doing to try and support performance in all areas, because if we do support it in all areas, it does help the areas that are rural. And obviously with a lot of those areas within Yorkshire, East Yorkshire, North Yorkshire, parts of Kirklees. So you're quite right. We need to make sure we've got an equality of service right across Yorkshire, not just in the high urban areas where we've got, dense centres of population. Local initiatives. Only thing I've sort of mentioned here is around the reconfiguration of services. We've been asked to provide a quality impact assessment to the CHFT board and to the reconfiguration transformation board on what would be the impact on Yorkshire Ambulance Service. Chances are that the reconfiguration is probably 4 to 5 years away from a point of view of impacting on us. So the only modelling we can do is the impact it would have now and the mitigation that we would see in place. The other challenge is that the clinical model at CHFT is not completely clear from an ambulance perspective. So I think we've got it in terms of our ambulance demand and where the ambulance demand would be conveyed to in terms of patients. What we haven't got is the lessons learned from when we did the Mid Yorkshire transformation, is the impact on patients stepping down from the acute site to the actual going back to Huddersfield. So that's the piece of the jigsaw puzzle that we're waiting for. So we're working collaboratively with CHFT to understand that. They know exactly where we are in terms of our modelling. We've provided assurance around our data, but the caveat to that is, chances are we will have to do this. We'll have to update the modelling in 3 or 4 years' time anyway, because the health economy is changing so fast, and which will probably be in a different position in 3 or 4 years. The impact may be a little bit less, it may be a little bit more, who knows. But at this point in time, this is where we are, and that's what they're going to publish within their business case, which is obviously a publicly owned document. a little bit about the ambulance vehicle preparation. So this is about the upgrade of sites and facilities at Huddersfield Ambulance Station. We've upgraded the facilities to make it a make-ready station. So what that means is, in essence, that the crews don't check their vehicles. It is all done for them. To bring us in line with CQC operations, infection prevention and control, and things like that. We don't want paramedic crews checking ambulances, stocking ambulances. We want them to turn up on station, have an equipped vehicle that is clean, ready to go, so they can get straight out. So we've put one of those in place at Huddersfield. It's working extremely effectively. We've followed a model that is consistent across Yorkshire Ambulance Service, and also the vehicles from Honley rotate into that system to be cleaned and upgraded as well. And it's working wonderfully well. Councillor Warner.
I have a slightly more diplomatic question from Lynn, and it's a topic that I also want to express something about, which is to do, she says, I have concerns with the increased incident cycle times for patients being conveyed from Huddersfield to the hospital, as opposed to the infirmary at the moment. And I feel that we will need to carefully monitor this going forward. Is there a related commencement date? And just to add to that, I knew that until the whole building works was completed in Halifax, the ambulances would still be going to HRI. But the biggest issue that concerns people on the street, as I'm sure you are well aware of, is this travel in an ambulance when they have to go all the way to Calderdale, because with the best will in the world, even though you've done some road improvements have been done, it's still a lot longer to get there, and that is concerning a lot of the public. And so I do think, Lynn's said, I think it needs to be monitored carefully. I think there's a lot of reassurance needed as well there.
Yeah, I totally agree. I was involved in all the sort of public consultation, and that point was made quite clearly on numerous occasions. I mean, that is the detail that we've gone into. So we've looked at all the activity by postcode. What is the incident cycle time now from that postcode to HRI? And then what we've done is we've looked if that was the same activity and it had to move to Calderdale, what is the increase in travel time? That travel time then becomes the amount of extra additional resource that we need, because if our crews are travelling longer, they're becoming less efficient at conveying patients, so we need more crews. And that's the sort of calculation we've done. So just to provide assurance, we have that level of data internally. We have a good idea of what that mitigation will be to put those additional resources in place to make sure there's no delays for patients. But to answer your question about the extended travel time, you're talking additional 5-10 minutes, with blue lights in addition. Our crews are highly trained to manage those patients, those additional 5-10 minutes. And when they arrive at that Calderdale site, it will be a state-of-the-art facility where they'll be received by, top-notch doctors. That's been the ethos all the way through this public consultation.
Thank you.
Can I just ask, I did also, when you were going through the categories, you didn't mention 3 and 4, and I'd just like to know what the difference between them is. Is that
Yeah, I didn't mention 3 and 4 because obviously the particular focus was on 1 and 2. But your 3s and 4s, there is no national response times for 3 and 4s. 3 and 4s, the response time for those are locally negotiated with commissioners. So those patients are low acuity, and it can be anything from sort of 2 to 4 hours, depending on what's been commissioned locally. But it can be anything in there. It could be it could be something like a wrist fracture, something like that. you know, that yes, you're going to need medical attention for, however, you're not going to die from that injury. However, there's an element of the patient's going to be in discomfort, needs splinted, needs an element of pain relief, so still does potentially need ambulance transport, but not via a fully trained paramedic travelling with blue lights and sirens. Councillor Smage.
Thank you.
Thank you. I just observed this meeting, but as usual, I've got a question. We did talk a lot on the Mid Yorkshire Trust reconfiguration about ambulances. We've
did.
been here before, haven't we? We've been here before. Obviously, the Joint Health Overview and Scrutiny for Calderwood Kirklees will obviously be looking at your impact assessments in detail. But I just wanted to check. I seem to remember we had a conversation before about the time it takes for transfer between hospitals, the time it takes for transfer, including the time it takes from getting from a ward or a department to the department. I just want to check that your impact assessment will include those times. It's not just from when they get to the ambulance and then they're taken off the ambulance. Can you just confirm that your impact assessment does account for things like that?
I can confirm it doesn't include that. The impact assessment we've done, we've put a robust methodology in, so it's quite explicit on what it includes and doesn't include. But it includes from the pickup time of the patient. So so it doesn't include the response time. It includes when we've actually made the decision to convey the patient to when the ambulance becomes clear. The work we did in Mid Yorkshire was specifically around the obstetric, and that's why that was a little bit different.
Right. Okay. All right. That's thank you for that answer. No doubt we'll go into that in far more detail because I think I will be asking that question again. Thank you.
Thank you. David, Dave, do you want to ask your question?
Yes. Thanks for the report. It's obviously you've had some really serious challenges over the last year or so. I just wanted to ask a question on Appendix 1, which shows the Category 1 and 2 response times for April and May.
Yes.
On the Category 2 responses for May, if I've interpreted the figures correctly, those response times seem quite high compared with the target of 18 minutes. Higher than of the previous 13 months. I just wondered if there was a particular reason for that. I appreciate it's only a month, but it looks a bit on the high side.
No, you're absolutely spot on and accurate in your interpretation of that. So, like I've said to you earlier, we would expect April, May, June to be our quiet months as we come out of winter. We would expect demand to be at its lowest. We'd expect our sickness absence to be around 3-4%. What we've experienced since the lockdown measures have continued to ease is we've seen demand increase beyond expectations. So our demand at the moment is comparable to a busy winter period, and our absence is also increasing. So like I say, we're running at 10% absence at the moment due to track and trace procedures and isolation. But our demand at the moment is running 30% over on Category 1 calls and around 10% per day on Category 2 calls. So we have not experienced that before. So just to answer your question, that is the reason why our response times are the way they are. And that is pandemic related. There was a question before around how those calls are broken down. So we measure our call demand by chief complaint. So just to look at those trends and patterns. Since the pandemic became evident, there is a business continuity card we've put in place. We call it Card 36, which is specifically a national contingency, a pandemic card, and that puts us into basically all UK ambulance services into a national contingency footing. So one of our biggest call categories that is increasing again at the moment is the pandemic card. That's coming to our top 5 call categories. So that is again inextricably linked to our increase in demands at the moment.
Thank you.
Thank you. Do we have any further questions? Liz, have you got your hand up again?
Yeah, please. I just wanted
Okay.
to know, because it's been an incredibly difficult time for everybody. We really appreciate the work that everybody's had to carry out over the past, 15 months. It's been really difficult. And I just wanted to know what support has been put in place for staff to help them should they feel they need support going forward.
That's a really good question, and I think what we have got in the ambulance service. I mean, our crews always do a difficult job. So these support services have not just been in place for the 15 months. We have had very robust support and welfare packages right from, as far back as I can remember. So to answer your question, we've got a very robust occupational health service that is bespoke to crew needs. We have got we've increased our frontline management and supervisory. We've put in place an enhanced post-incident care process. So again, that's not unique to the pandemic, but obviously crews are attending traumatic incidents all the time, and depending on individual circumstances. But that basically means a post-incident debrief with an appropriate trained supervisor to look for signs of post-traumatic stress disorder, and also we'll put in welfare checks that go beyond that. We've invested a lot in mental health first aider courses for us frontline supervisors, admin staff, paramedics. So again, they can provide that support. During the pandemic, we put managers at every ED department on the basis that there were no crews on station because they were out working all day. So the management were put at the emergency departments. We provided food, welfare facilities, respite for crews because they were working extremely hard. They were working for long periods of time in PPE, which add, all sorts of impacts on their mental health and well-being, which was recognised. So those are the main headline points, Councillor Smage, but I could go on. There were lots of support mechanisms for staff.
Councillor Armour.
Yes, thank you. Just moving now to in the sense of staff side, the customer service side, if you like. A couple of weeks back, I had the misfortune to be involved in a traffic accident. When a car behind ran into my car, it became very quickly apparent the driver had had a major medical episode and he died a couple of hours later. But on the 999 call, we got all the immediate details out. But then, bear in mind, I was in a state of shock. And what felt like 20 questions. Has he COVID? I don't know. I've never met the gentleman. Now, that surely should have stopped that line of questioning. Because they're working from a script, I understand that. But lots and lots of personal questions that I can't answer. I've never met the man. Can we just cut back? When you get, I don't know, I've never met the person, can we just abandon that script?
It's hard to comment without listening to the actual tapes, but obviously you're right. You're quite right. It is a script, and it's nationally written, and the person taking the call has to go through the script in order to make sure that any sort of scene safety questions around any hazards at RTC, or because of the situation we're in now, any sort of COVID related symptoms, because obviously the crew will put on appropriate PPE according to the to the clinical need of the patient, from either a simple face mask and gown to the full astronaut kit that they have. So it's important that we ask those questions. But I do apologise if they feel onerous. But just to give you some assurance, they do not delay the ambulance. While those questions are being taken, that address has landed on the dispatcher's desk and the ambulance has been dispatched. So just to provide reassurance, I think the public don't realise that. They think they're delaying the ambulance by asking all these questions, but especially in category 1, category 2 calls, the ambulance has probably already been dispatched, and that information is sent to the crew while they're en route with blue lights. To you.
Yeah, thank you.
Thank you. Leslie, do you want to come back in? You're on mute.
So,
Leslie, we can't hear you.
yes, okay, sorry. It's a couple of more things from Lynn. One was referred to right at the beginning. You referred to North Clees and Greater Huddersfield. She was asking, should it be North and South Kirklees? That was just a question of clarification of terms she wanted me to raise. The other thing she wanted me to say, and obviously I'd like to add to this, you know, we're very grateful, everybody is, for the sheer amount of work that everyone's doing. And what Lynn wanted to say, in a particular change of practice in South Kirklees, the whole way of getting the patient transport service has been, was quite complicated in the past. And it's now been much more efficient. And so she wanted to say that she was very impressed with the recent booking and use of one, and say, you know, done the changes.
Oh, that's good to hear. I'll pass that on to our patient transport colleagues. Yeah, they try and make the booking process as streamlined as possible, just to make it not as onerous for the person making the booking. In terms of the boundaries, I'm not too sure. The boundaries I'm talking about are the clinical commissioning group boundaries. So that's North Kirklees and Wakefield CCG. I understand those are changing at the moment and in flux with the changes in boundaries and primary care networks and things like that, and ICS boundaries. But at the moment, the historical data is still managed under the old CCG boundaries.
Thank you. Leslie, are you wanting to come back in? Leslie, I can't hear you.
I was trying to shake my head saying no. Okay, sorry.
All right, okay. Is there any further questions from the panel members? Okay, well, thank you for attending today. The panel very much appreciates the valuable work that you do as a first port of call for all sorts of emergencies. And thank you for the excellent insight that you've given us into the work of Yaz and the challenges that you've had over the year. I'd like to suggest to the panel that we note the information presented to us today, and in any sort of future meetings that we call you back, if you could include the pickup and drop-off times, because this has been an issue that has been raised on a number of occasions with different councillors. So if you could include that in any sort of future meetings that we have with yourselves, I'd really appreciate that. And thank you so much for attending today. Leslie, are you wanting to come back in for something?
Yeah, sorry, I've overlooked one of Lynn's questions, which was, did you have any problems with the supply and quality of the PPE? Have you had any problems?
To answer your question, no. So the gold standard PPE, we were lucky to procure that 12 months prior to the pandemic. So, and that was because we had problems doing the fit testing for the specialist masks. That's why we went for the hood solution. But in terms of the PPE, we never had any problems.
Okay, great.
Thank you. Are you done, Leslie?
Yeah, that's it.
Okay, thank you. Thank you once again to the ambulance service for attending. And have you noted the point, or Richard will be in touch with you?
Yeah, I'll clarify it for Richard if you don't mind. But thank you very much for your invite, and thank you for your interest. It's very much appreciated.
Yeah, thank you.
You're welcome. Thank you. If we can move on to the next item, which is the COVID-19 update. We have Jane O'Donnell.
Good afternoon.
Hello, Jane.
Hello. I'm having a few IT problems today. I keep losing my connection, and I've messaged Richard to say if he could possibly share the slides. I have a couple of updates, but I'm not able to share today, I'm afraid.
Okay.
Are you able to do that, Richard?
Yes, I can do that.
Thank you.
Just bear with me whilst I locate it.
Shall we just have a quick few minutes break while you do that, Richard, or are you sorted?
Should be coming up
All right, it
now.
has. Yes, it has. Thank you.
Is that okay for you, Jane?
Yeah, that's fine. I'll just make sure I can move on. So that's lovely. So I have an update from the slide what you will have received in your pack. So the number of confirmed cases in Kirklees up to the 30th of June now is 38,734 cases. And in the last 7 days, in the last week, we've had 1,021 confirmed cases. This rate is driven by the 10 to 19s and the 20 to 29-year-olds. You obviously all seen in the media and locally that we've seen increased number of cases in these age cohorts in schools, colleges. We also, when we've done the contact tracing, we've seen obviously increase due to the football and obviously people mixing more widely. We're now ranked 58th out of 149 local authorities. So we are in West Yorkshire with the lowest. We have the lowest rate compared to other local authorities. Our rate is now at 232.2 per 100,000 population. That is to week ending the 30th of June. With Wakefield having 375 per 100,000. Leeds is the highest rate at present at 423.3, followed by then, as I say, Wakefield, and then Calderdale at 332, and Bradford is down to 267.3. So as I say, we still have the lowest rate, but all areas nationally have seen an increase in cases. I then wanted to touch upon the in the Kirklees enhanced response. As you're aware, in mid-May, the Secretary of State for Health at that time, Matt Hancock, announced that Kirklees had been identified as an area of concern due to increases of the Delta variant and increasing case numbers across Kirklees. So as part of being an enhanced response area, we were able to do search testing, enhanced contact tracing, enhanced support offer for people to self-isolate to bring transmission down rates locally, and the ability to carry out turbo. We obviously must have had a crystal ball. We obviously were aware of other areas having to search test, so we developed a search testing plan, which we then did a tabletop exercise with key partners to ensure how it worked and modified. So I think that stood us in good stead for our search testing plan. As part of the search testing, we were able to deploy extra mobile testing units in areas of enduring transmission. So you're aware we put testing units in Honley, Heckman Dwight. We put an extra one also in Saviltown. And also our established mobile testing units and local walk-up test sites were able to offer asymptomatic PCR tests as well. We worked with 5 of our high schools across Kirklees where we'd seen a real rapid increase in infection rates, and they worked really hard with us to enable that we offered PCR testing to the pupils, staff, and their families. So just a little bit about the results from the surge testing. So at the mobile testing units and local testing sites, approximately 2,500 kids were registered for asymptomatic testing, with 230 positive cases identified. 4,500 PCR tests were hand delivered via the door knockers in the search testing areas, with 80 people testing positive. And in the 5 high schools, we actually gave out 7,000 PCR test kits and identified 162 positive cases. So you can see the amount of work what went in. But the important thing was to have those conversations with those communities of the importance of hands, face, space, and when you were eligible for your vaccine to obviously come forward for the vaccine. Mentioning a little bit about test and trace. The in blue is the actual cases. As part of being a search testing area, we could do enhanced contact tracing. This meant that any positive cases into Kirklees were actually prioritised by the National Contact Tracing Service, so that they didn't go into a queue system where they're usually are queued for just over 24 hours before they come to the local contact tracing service. So if they weren't contacted by the national team within a number of hours, they went to the local contact tracing service. So we actually reviewed, now we've reviewed 593 cases. We've finalised 73% of those cases, and on average have continued to follow up more than 15 cases a day. So we can see that our actual uptake of cases is completed within 7 days with just under 89%. And with contacts, a very high percentage of contacts are followed up, which is 97.1%. What happens with the contacts is we actually use in Kirklees a door knocking service, which are environmental health colleagues, where they receive the cases of each positive case each day. We then go and do a door knocking to again offer support, explain the importance of self-isolation and identify contacts. We're also using the door knocking service where we're seeing clusters of cases to home down on those areas and offer PCR tests to those contacts. So it is actually reaping benefits, even though you may see that we're still seeing high case rates. As part of the search testing and enhanced response, we also were able to do COVID vaccinations, and as part of that preliminary work, which was already established, we'd done a COVID vaccination equality impact assessment, and this was in line with guidance from NHS England colleagues and working very closely with CCG colleagues, NHS partners on this. So based on the findings from the equality impact assessment, the following groups were identified. I'm not going to go through them each individually. We obviously worked very closely with Community Champions programme to prioritise the groups. They've done an amazing video to help promote in the BAME communities and people with disabilities. We've assisted with transport schemes to get people to, if they have mobility problems, to get them for the vaccine. We've used social prescribers for supporting uptake with outreach work. We've been following up those who have declined the vaccine through social prescribers and Community Plus. We've worked with faith leaders and communities to do targeted comms, and as you're all aware, we've been doing a lot of pop-up vaccination sites across Kirklees. These have been exceptionally well received because people who previously were eligible had not taken up the vaccine, when it's coming into their area, have gone for the vaccine. We've worked with some workplaces as well to offer vaccine in the workplace, and again have had good uptake. We've obviously did targeted work during Ramadan, and we've done targeted work with rust sleepers, the homeless, asylum seekers and refugees. This work continues, and we're working very closely with our local colleagues and our Housing Solution colleagues on promoting vaccine. Obviously, as part of our Kirklees White communication strategy, we're wanting to promote uptake and obviously seeing it as a positive social norm, and wanting to address the 3 C's: confidence, convenience and complacency. As part of the search testing, as I said before, we were able to, the Director of Public Health was able to be flexible to increase the target area, the specific target groups, what we could actually focus on. So we obviously continued, we're recognising that it obviously a universal approach, and as I say, we used the ongoing collaboration with manufacturing sites and the roving vaccine model, targeting communities with enduring transmission. We've obviously got other dates which we're publicising on the Kirklees website, and we share that with partners for them to obviously publicise as well. I finally wanted to go on to about the uptake of the vaccine. Now, the data has been updated, and in dose 1 in uptake in people aged over 40 years, this is data up to the 27th of June. In Ravensthorpe, we've got the lowest uptake of 78%, followed by Birkby of 80% and Batley Central of 82%. The other areas what are greyed out have achieved the 90%. So obviously work is continuing with those specific areas as detailed before. So thank you.
Thank you,
Richard.
Yeah, thank you for that, Jane. Before I open up for questions, the vaccine programme, Jane, seems to be quite successful overall. Considering that the restrictions will be appearing in a couple of weeks, are there any plans in place for public health officers to offer any advice or information, particularly in public places, you know, to ensure that public safety is, you know, adhered to? Because currently we have enforcement in pubs and clubs, etc., but 19th of July, those guidelines may not be available to them.
Yeah, I've been discussing this with Rachel this week, because obviously we're waiting for the formal announcement on the 12th whether restrictions will be lifted. But we see that obviously we want to ensure that people feel safe, so we need to ensure that people are considerate when people want to continue wearing face coverings if they wish to do so. We're awaiting some updated guidance on working safely, which obviously we will then promote, particularly to businesses, because as you rightly say, it will be no longer legislation; it will be guidance. So we will very much be ensuring that, obviously, saying to people, be considerate of people for face space going forward, but acknowledging that it is an individual choice, but consideration for people who want to continue wearing face coverings if they wish to do so.
Thank you. Dave, you have a question?
Yes, thank you. Just following up on that, really. I wondered whether there would be like to be any specific advice locally in terms of the continued wearing of masks in shops and on public transport.
We're waiting, as I said, we are waiting for some updated guidance. So I think it depends again what the updated guidance does say. But I think, as I say, I think from a Kirklees position, we will probably be going down the following national guidance, and also speaking to our other West Yorkshire local authorities, so that we hopefully are all obviously of the same stance.
Okay, and I've got a couple more questions, but it may be that these need to be responded to by your health colleagues. The first one is about the current rate of hospitalisations within Kirklees, and the second one is about the current impact of long COVID. Yeah,
I can take those questions back to NHS colleagues to answer, and obviously give a response back to Richard to share with colleagues.
Okay, thank you.
So it's long COVID.
Yeah.
And rate of hospitalisation.
Yeah, and the trend on hospitalisations. Yeah.
Yeah.
Thank you.
Yeah, thank you.
Any further questions? Okay. Well, thank you.
Sorry, I had questions.
Sorry, I can't see your hand raised, Leslie.
All right, I put it in the chat box, because sometimes I can get my hand raised and sometimes I can't. Okay, sorry.
That's fine.
So the questions, there's a couple, first of all, from Lynn, who's not here. She says, has any liaison been undertaken with Kirklees food banks and also with the Huddersfield Mission and any other similar venues in North Kirklees with regard to identifying individuals for vaccination motivation purposes?
We've done a lot of work with our food banks in public health and with local communities. As I say in the presentation, we've worked very closely with these organisations, with third sector organisations as well, to get that message out about the importance of vaccination.
The other question, obviously, I live in Slough, so we were obviously one of the drop-in centres, and I've been volunteering there. But what is a little alarming is the speed with which the rules change. So 2 weeks ago, we were telling people who'd had one of the jabs that they could have the second one within 3 weeks. Now it's back to 8 weeks. And I'm just wondering how you are managing this movable feast. And the other thing to feedback, which I'm sure is something you are only too aware of, I've been contacted by many older people who are seriously frightened about this optional mask, because, you know, I think it's going to mean more of them will not feel confident going to shops.
As regards the interval between doses, obviously the NHS issued guidance that anyone under 40 can have their second dose within 8 weeks. Obviously, it's a clinical decision about whether that distance for the second dose is reduced below that, but obviously these very strict criteria to reduce it below 8 weeks for your second dose. But as I say, that is a clinical decision between the prescriber and that patient.
Was that okay?
Yeah, no, it's okay. I do think this July the 19th is scaring the socks off a lot of people. And I don't know whether Kirklees can, you know, what it can do to reassure a lot of people, and or perhaps decide that our shops should still request mask wearing on public transport.
as I say, we are waiting updated guidance on working safely, and obviously as part of a business's risk assessment, they obviously have to have a health and safety risk assessment, and they will obviously have to ensure that as part of that, you know, COVID still is taken into consideration. As I say, I think we just have to wait for some further updated guidance to come through.
Okay, thanks.
Okay, thank you. If there's no further comments or questions for Jane, I'd like to thank you, Jane, for all the hard work that you've been doing to protect the public. And I'd like the panel to note the information that Jane has presented to us, and the questions that Dave raised with yourselves, you will get that back to us at another point. Is that okay?
I will.
Thank you very much.
Thank you. Thank you.
Thank you for attending. Okay, if we can move on to the next item, which is setting the work programme for 21-22. We have Richard Parry who is joining us. If we can look at the work programme, and Richard Dunn, do you want to take us through that, or you know, do we just note that?
It's entirely up to you, Councillor Mann. I mean, my view would be this: we've obviously drafted this on the basis of the input from the workshop.
Yeah.
I think it'd be interesting to see, for example, if Richard has any comments he may wish to make in relation to some of those items. But ultimately, it's about the panel making a decision in terms of whether they're comfortable now with the items that we've got included on the work programme, and also whether they're happy, because we talked about having some overarching themes included, which I've tried to do. So it's obviously, you know, obviously welcome feedback from panel members whether they're happy that I've captured all of the points that they highlighted they would wish to sort of cover as part of the work programme going forward. And once we've done that, if it's possible, we can maybe just touch a little bit on the forward agenda plan as well. So just to highlight some of the key issues that maybe you'll want to look to cover in the next few months.
Thank you. Richard Parry, would you like an input into this item?
Thank you. I mean, it feels a very helpful work programme. I wonder whether, just reflecting now on section 2, the sort of impact of COVID, whether there's something more we might pick up in there around the broader impact on social care and people who may be liable to need some additional support. Age UK very recently published a piece of research that suggests there's an 11% increase in the numbers of older people with social care needs as a consequence, really, of much reduced mobility over the last 15 months. Yeah, so a lot of the things that people would normally have done that kept them active and connected, it's not been possible to do. And that's feeding through really in terms of increased care needs. And so whilst the areas of focus that are in section 2 are really helpful, I wonder whether we might just add a bit more about that impact. It sort of alludes to the point that Councillor Warner was making around, you know, the risk of continued isolation of some people.
Okay, we can do.
Chair, could I just come in on that item 2? It's just to add and suggest adding a couple of additional things there. One is perhaps a reference. One of the bullet points perhaps could be the impact of long COVID, because I think that's going to be a continuing issue. And the final bullet point that's mentioned there is lessons learned. And I just wonder whether there was any proposal for any kind of interagency session. I don't mean an inquiry, just a session which looks at what lessons have been learned over the past 15, 18 months, and how perhaps practice can be adapted in the future to take account of those lessons.
Yeah, good point. Is there any further comments? Richard, are you wanted to come back? Richard Parry.
Yes, just on that point, I wonder, what I'd suggest is that actually there's been a lot of lessons learned going through which are sort of leading almost to changes in the way we're designing for the future. So we've learned an awful lot, for instance, around the vaccination delivery program and how you need to do things differently in different communities. There's now already impacting on the way we start to think about health inequality. So I wonder, rather, almost as you go through each of those items, there's something about what has the last 15 months taught us. So around the integration agenda, we've learned an awful lot over the last 15 months because of the way services have had to work differently and together, and that's already feeding into our design work for the new integrated care partnerships.
Yeah. Dave, are you wanting to come back in?
Yes, if possible. Just
yeah.
a couple of things. We've referred to the deferred workshop on integrated care systems, so that hopefully will be included in the not too distant future. We've also had reference on a number of occasions to a possible workshop on SWIFT on mental health issues, and I wanted to mention it's picked up in the minutes. I made a suggestion of a new issue to look at, which is around the health problems arising from toxic air. And there's been quite a bit of publicity about some of the problems that exist recently. And I just wonder whether we could consider adding that as an issue, a health issue in relation to air pollution.
Absolutely, yeah. We could look at that.
Thank you.
Bill, do you have your hand up?
Not knowingly.
All right, okay. Leslie, are you wanting to come back in?
Yeah, yes. Lynn's just raised a few points as well from her notes she gave us about to everyone to be aware that the council is currently holding this of co-production workshops with service users, carers and community partners, focus on the proposal to merge the Gateway to Care service and the Locala single point of contact. Also reviewing the and revision of the direct payment. So she wanted to raise that. Also wanted to raise item 4 about the digital technology, that it's important to ensure that a blended person-centered approach is maintained going forward, as online activity, as we well know, does not suit everyone. And then on item 5, she said she would like to see a focus on the well-being of and proactive support for unpaid carers. There are variations within the different NHS. For example, the Mid Yorkshire Trust and South West Yorkshire Partnership both have a carer passport, and so things are documented. She's hoping that within the West Yorkshire and Harrogate Health and Care Partnership footprint, a carer lanyard badge can be put in place. And she's given more information on that in the notes. She also mentions, with regard to suicide prevention, some funding used via tender process to provide additional community support services. And also she thinks that the panel will benefit from the insight that will be gained from participating in a workshop with the South West Yorkshire Partnership NHS Foundation Trust. So those are all points raised by Lynn.
Okay, well, thank you for that. I can look through some of those points with Richard outside of this meeting and come back to you on that. Is that okay? Richard, yeah.
Yeah, thanks, Chair. It was really just to sort of highlight a couple of issues, really. Obviously, Dave's has put forward the inclusion of a potentially an extra item on air pollution, obviously, and I've picked up the clear consensus that workshops will be helpful both in terms of the white paper and obviously Swift, and they will be stuff that we can obviously factor in. My only concern is that when we come onto the agenda plan, we've got obviously a limited number of formal meetings that are currently scheduled. The items that we've got on already included on the work programme are quite complex. Will probably take up a lot of our time in relation to some of those meetings. So I just want to sort of highlight, I guess, that we, there's going to have, I don't want an expectation that we will necessarily be able to cover in detail all of the issues, obviously, that we've got down on the list. And I think it may be very prudent to maybe look closely at the prioritisation of these issues. And again, Richard might be able to help here in terms to some of them might have timescales attached to them where we might be more prudent to maybe look at some of those where we know decisions are coming up, or whether there is some movement going forward on some of those key issues. So I've made a note of everything, so that's fine. But I just think, I suppose it's about managing expectation. I guess
that's true. Yeah, absolutely.
Thank you.
Yeah. Fazila, are you wanting to? You had your hand raised. Are you wanting to ask a question?
Yeah. So just on point 4, digital technology, perhaps we could have a look at the new legislations in regards to patient information going all digital. And I know there's obviously a lot of concerns being raised about how patients' information will be kept with on digital, and how they have to manage their own data, and seeing what kind of a role the council or we can play on this, and make sure that the patients obviously or the people know what's happening, because there's a lot of uncertainty about what's going on in terms of the new legislations.
Good point. Yeah, thank you for that. Any further comments? Were you wanting to come back in, Richard Parry? Okay. Thank you for that. But I mean, this is a live working document, and we can come back to it at each meeting and see how we're progressing on the items, and see how we want to prioritise future items. Richard, are you wanting to come back in?
If I may, all I wanted to try and do as well is, if we can, and I'm happy if you want to do it outside of this meeting, but I'm just conscious that we've got obviously a meeting scheduled for August, and we've obviously got another one again in October, and it's a case of whether members want to start looking now at sort of prioritising some of those issues coming forward, because we've already got some issues currently potentially scheduled for those meetings, and so obviously it's going to get quite busy in terms of what we're going to be covering. So I don't know how you want to do that. Whether you want to do that now, or whether you prefer to do that outside of the meeting, I guess it's down to you and the panel to decide.
I would say outside of the meeting, and then we can come back.
Okay.
At the next meeting with
fine.
Yeah, with an updated plan.
Yeah.
Is that okay?
Yeah, that's
because I'm conscious that we've got another item.
Yeah.
And officers waiting for the next item.
Yeah, that's fine. Thank you.
Thank you, Richard, for attending. If you wish to leave, you're welcome to do so, or you can stay on.
Thank you.
Vivian.
Sorry, can I just come in again? I'm sorry. It's just I wanted to know. I understand leaving the date, but what concerns me is we arranged a date for the workshop on the white paper, which I think is really urgent. And obviously many members couldn't come. So I think it's really urgent that we sort a date as soon as we can, and that as many members as possible try and get there.
Yeah, we're talking about the work programme.
Oh, okay.
We will reschedule that date. But in terms of the work programme, rather than discussing the details of that here and now, if I work with Richard Dunn on that, and we can come back with an updated plan at the next meeting.
Okay, thank you.
Vivian?
Thanks, Habiban. It's still raising those concerns that I've got about patients travelling between Dewsbury and Pinderfields. I did send you and Richard an email.
You did, yes.
It was a bit heated, but the person that relayed it to me is they're quite a strong person. but they're incredibly upset and in tears over it. And it wasn't quite right to raise it with Yorkshire Ambulance Service, but this person had a blood pressure of 240, which is significantly raised. And they put her in a taxi to transport her from Dewsbury to Pinderfields. If something had have happened, there's no medical support. And this is not the only case. There's another one come to light via Murfield Matters, again, where they're being put at risk. They're being told to go to Dewsbury, A&E for starters, Dewsbury triage, and then they ship them off to Pinderfields. And it's the same treatment. They had a fractured ankle. There was no porter, no one on hand with a wheelchair, no one to greet them, no one to help them. And I'm aware that we have a lot of people coming out and giving us briefings on what's going on, but we never get feedback from the users, the service users. And
that's a role really that Health Watch sort of undertake. You know, Richard, are you wanting to come in there?
Yeah, thank you. In fact, that's exactly what I was going to say, is that just so you're aware, Vivian, we have liaised with Health Watch Kirklees on the matter that you raised, and they are, well, at the moment they are provisionally scheduled to come to the next meeting for two reasons. One, to share their work programme with the panel, because we did say, and it's on our work programme, we want to obviously develop our working relationship with them, but also I have asked them to look at that issue to see whether they're hearing anything as well, because obviously, as Councillor Zaman has said, they are effectively the watchdog, aren't they? They will listen to and hear about complaints, about issues, for example, but both negative and positive issues, obviously, experiences from users. So it's something we haven't forgotten about. So we will look into it. But I think what Health Watch have highlighted is obviously all frontline services have been and still are under unprecedented pressure and challenges. So they want us to sort of look at it, but in that context as well. But your points hadn't been forgotten, Vivian. We are following them up. And hopefully when we have our discussions with Health Watch, we can sort of come to some kind of conclusions how to take it forward.
Thanks for that, Richard. I know the pressures that they've been under, but I also know that patients presenting with other things shouldn't be neglected or suffer.
Yeah, I think that's
absolutely.
Yeah, that's agreed.
Everybody.
Yeah, that's agreed.
Thank you.
Okay, thank you for that. If we can move on to the next item, that is Child Development Service, and we have Nicola Bailey from the who is the Transformation Programme from Calderdale and Huddersfield NHS Trust Foundation, and Katie Booth, the Nurse Manager of the Child Development Service. So I'll pass you on to them now, and then they can give you a quick update on the service. Nicola, do you want to go?
Yeah, thank you, Chair. Good afternoon, everybody. I'll just introduce myself and get Katie to introduce herself, and then I've got a couple of slides just to put up to describe to you the work we've been doing with the service, and then we can pause at the end for comments and questions. So my name is Nicola Bailey, and I am the Programme Manager working at Calderdale and Huddersfield NHS Foundation Trust. Katie, do you want to introduce yourself?
Yeah, thanks, Nicola. My name's Katie Booth and I'm the Clinical Nurse Manager for the Rainbow Child Development Service at Calderdale Royal Hospital and Children's Outpatients at Calderdale and Huddersfield NHS Trust.
Lovely, thanks, Katie. So I'll just pop the slides up on the screen now. There aren't too many of them, but I thought it would just be helpful to walk through a few slides to outline the work we've been doing within the trust with the service. So the first slide just describes that the Child Development Service are a service and a team that are currently based at the Rainbow Development Centre at Calderdale Royal Hospital, and they've been based there since 2015. Over the last almost 12 months now, we've been engaging with the team, looking at the model of care that they offer users and families locally across Calderdale and Greater Huddersfield, and looking at opportunities to create a central community hub for this service, and in particular opportunities to co-locate them with some specialist nursing input and community therapies who are also services that these families access. A little bit of information on this slide about the service itself, and families across Calderdale and Greater Huddersfield attend the Child Development Service at Calderdale and Huddersfield Foundation Trust after referral for specialist support and care for their children. The service supports children and young people aged 0 to 18 years old who have complex needs, developmental delay and disabilities. The service also has paediatric consultant-led clinics several times a week for children and young people with neurodisabilities, social communication difficulties and epilepsy. And in addition, the children seen in the clinic, there's a caseload around 87 long-term children currently. And these children are seen by the Child Development Assistants for early, regular intervention around their development. And these children are aged between 0 and 5 years. These children, these 87 children, of those 45 reside in Calderdale and 42 in Huddersfield. So hopefully that just gives you a sense of the service and also the users and the families that the service is currently supporting. On the slide here, we've tried to describe what the team described as their core facilities required in the community hub to offer the best possible service to our families. And as these families require support from multiple agencies, they often have to travel at the minute to multiple bases for intervention. And it's our ambition to create a one-stop shop for these families. We'd like to ensure we provide adequate access to care for all children and families. And through the work we've been doing over the last 10 to 12 months or so, the team felt it was absolutely fundamental to have a service situated between obviously Calderdale and Huddersfield, and ease of access to the premises was top priority as part of these discussions. A more central position across the locality is absolutely essential, and that's been regularly fed back to the team from the families they support. Another important factor for the service is around identifying a space that can accommodate some of those other support services I mentioned earlier, required by the families like the specialist nursing teams and the community therapy teams, to reduce the need for multiple appointments in different locations, to reduce time, travel, stress and cost, of course, for these families. Many of the children and young people accessing our service are wheelchair users, so adequate, safe parking and access is always going to be a must for these families, something that they don't currently have at Calderdale Royal Hospital in the facilities there. So the slide I've popped up now just describes the work we've done around appraising a range of options to establish a community hub for this service in the middle of our patch. And following an exercise to identify suitable premises, there were several options explored, which were all subject to a visit from the team, as well as colleagues from our own estates and facilities department. We then did an appraisal piece of work that looked at several critical success factors and evaluated each of those options against each of those success factors for the service. And a full equality and quality impact assessment has also been completed on each of the options to assess the impact of the move of each option on service users, families, as well as colleagues within the team. A preferred option was determined from this work of the Clock House building, which is in Elland, and this option has been shared and supported internally within the Trust and also with CCG colleagues. So the next steps with the work that I've just described to you is that we are in the process of finalising a communications and engagement plan, which includes details on how we intend to communicate information to families, local people, as well as other stakeholders. But most importantly, how we want to engage with those families and involve them in the work to help us design the new facilities. So that's the end of my slides, and in summary, I just wanted to say that we are really excited about the opportunities this move gives us to improve the service for our families, moving the service closer to Huddersfield families and offering facilities that will enhance the access and overall experience from our families, and we really look forward to working with them to help get their input into shaping the design of the facilities. So I'll pause there and take down my slides. Thank you.
Thank you. So in a nutshell, the Trust are looking for support of the panel and looking for comments on their plans for the new facility and also on their engagement plan. Dave, you've got your hand up. Would you like to come in first?
Yes, thank you. A couple of things. First of all, I think on your facilities slide, it referred to public transport links. So I just wondered, in terms of the Clockhouse building, how well that's located in terms of existing bus routes, and also maybe looking forward a bit. I think there's a proposed new railway station for Elland. I just wondered how close it might be to that. That's the first point. Second point is, I'm not sure for this patient group how important outside provision might be, like a garden, but I just wonder whether that's a possibility to take into account. And then finally, in relation to the communication and engagement plan, is that being carried out in-house, or are you taking somebody externally to run that plan? Thank you.
Lovely, thanks, Dave. So I'm going to ask Katie to come in and just give a little bit more information in response to the first two questions around public transport links, because that has been a key part of the work that the team have done, and also the outside garden space, and then I can come back on the communications and engagement. So over to you, Katie.
Hi, thanks for those questions, Dave. So yeah, access was our number one priority really for families, and obviously considering that some of our families use public transport and the difficulties they have currently getting from Huddersfield specifically to the Calderdale Royal Hospital. My understanding is a lot of our families have to get 2 buses to the Calderdale Royal site from Huddersfield bus station itself. We've looked at the Clockhouse in Elland is fairly central to Elland Town Centre, and there is a bus service that runs directly from Huddersfield bus station to Elland, and Calderdale Halifax bus station to Elland. So we felt the public transport links were much better for well, they were equally better for both sides of the community, if not much better for the Kirklees families. Obviously Nicola said we looked at a range of options, and we also considered walking distance from the bus stops and things. So if you pitch Calderdale Royal at the minute, if a Kirklees family has got 2 buses from Huddersfield, got off the bus stop at Salthebble near Calderdale Royal, it's an uphill walk to our department at the minute. So when we were looking at the new venues and things that were on offer, that was very key as well, the walk from the bus stop to the proposed new venue, and we would say it's about a 5-minute walk to the new building at Elland. In terms of an outside area, yes, that is extremely important to our families and children, and the Clockhouse hasn't got an outside area at the minute, but will have it as part of the proposal of the new design. We have insisted on an outside area, so yes, it will have that provision for families as well.
Good, thank you.
Thanks, Katie. And just coming back to the communications and engagement plan, it's a plan that we've developed in-house. It's been co-designed with the team, with Katie and her team, because they know the families better, better than any of us. And it does include extensive engagement. We're really keen to get that engagement with the families as soon as possible to get their thoughts and inputs into it, but also to understand any concerns or anxieties or worries that they might have that we're keen to hear as soon as possible. So it is a plan that we'll be delivering in-house, although we have also been in discussions with engagement lead colleagues from the CCG, and we are also intending on reaching out to Health Watch to get their views and their inputs into the plan and how we deliver that engagement.
Good, thank you. I'm glad to hear that. Thank you.
Are members able to suggest points of contacts or groups where you could go for this engagement? Nicola.
Yeah, if there are specific ideas, absolutely. Yeah, please do share them and send them on, and we'll ensure that we capture them as part of this. Absolutely.
Thank you. Is there any further comments or suggestions of how they could get involved, how communities could get more involved in the proposals? Okay, well, if there's no further comments, I'd like to thank you both for attending the meeting. Katie, are you wanting to come back in? Sorry.
I was just going to say, as part of the communication strategy that has been developed, you know, we have the parent carers organisations in Huddersfield on that, as well as Calderdale, people like Shebang and the Down syndrome, you know, users of the service, so parent carer organisations. So, you know, and organisations that aren't necessarily health, like the SEND teams in the council and things. So, but any advice would be much appreciated in case we've missed things.
Leslie?
Yeah, just a quick question in terms of, I presume you're going through doctor surgeries and things. I mean, I'm lucky enough in Slough where we've got the big new operation almost. It's more, Colne Valley Surgery has moved into quite a large position with open spaces. And I have seen, you know, a few wheelchair users coming there who didn't used to come to the old doctors because they couldn't access it. So I just wondered, is this proposal going out to all doctor surgeries for feedback, or to community workers who are working, you know, like the hub coordinators in each area who work with targeted families through schools? Are they all being made aware of this?
Yeah, thanks, Leslie. I think, as Katie said, we've got an extensive list of stakeholders that we've compiled as part of the strategy and the plan that we described. So we will be ensuring that all those stakeholders are aware and informed of the work and are given an opportunity to be involved in helping to shape that. So that's absolutely part of our plan, and something that we're really keen to kick off as soon as possible, so we can start to have those conversations and get their input sooner rather than later, before we enter into any design work.
What's the time? How many years ahead are you looking for this happening? Big question, of course.
Yeah, big question, and hopefully not numbers of years. So we're hoping that within the next 12 months, we will have done the work and will have moved the service into the new premises. So probably spring, summer 2022.
Thank you. Hope it goes well.
Thank you. Any further comments? Okay then. So if I could ask the panel to note this briefing for the design and construction work required to create the community hub and a facility fit for purpose, and also that we support this proposal, and the next steps, if we can see the outcomes for the engagement work, and maybe, you know, before it's actually confirmed, if maybe you come back to the panel for any further sort of suggestions that they may want to have input on that, if that's okay.
Of course, yeah, that's great. We'd be delighted to come back.
Okay, well, thank you very much again for attending at short notice and for having an input into the scrutiny panel this afternoon.
Thank you very much.
Thank you very much.
Okay, thank you. So that brings us to the end of our agenda items for this afternoon. And I would like to thank everybody for their participation in the meeting this afternoon. And we hope to see you at the next meeting. Thank you, everybody, and thank you for participating. Have a nice afternoon.
You too.
Thank you. Bye-bye.